Good morning and welcome to a very special Grand Rounds. I'm very excited to be here today to introduce Robert Listernick, MD, better known as Bob. Now, Bob is an incredible human being, and when we think of the word Lurie Children's Hospital and Children's Memorial, immediately you think of Bob. Bob was born in New York City and still kind of talks that way. He is a professor at Northwestern University. He went and did his undergraduate degree back on the East Coast at the University of Rochester with the highest distinguishment. I have to be careful because he has his degrees in English and biology, so I must speak with good grammar and syntax. And then went to the University of Pennsylvania School of Medicine, where he graduated in 1979. And then made the fatal mistake of doing his residency at the Children's Memorial Hospital, now Lurie Children's Hospital, back in 1979. Bob's honors are so long that I would take the entire hour, but I did want to emphasize that he is Phi Beta Kappa, and I think amazing that he was awarded by the residents at Children's Memorial and Lurie Children's Hospital as Outstanding Teacher of the Year in 1990, 2005, 2006, 2008, 2009, 2010. Gave it away for a couple of years and picked it back up in 2013, 14, 16, 17, and as recently as last year. He's also been inducted in the AOA as a faculty member, has won the NF Association Network Advocate of the Hope Award of the Year in 2019, is a member of the Society for Pediatric Research, edited multiple journals, is a prolific writer, and has really established a world-class neurofibromatosis program in Chicago. Even more importantly, truthfully, Bob is the heart and soul of Lurie Children's Hospital, and when I arrived there in 1997, I knew to latch on to this significant clinician. One thing people don't know is that Bob also has run for 20 years what we would call firm rounds in Chicago, which is interesting in difficult cases that then are presented so that the faculty, residents, and students can figure out what's going on. This leads to him constantly poking around in people's clinics looking for what was happening and what was interesting. But the side effect that I can tell you I used many times was when I'd see a child that I'd be treating for a brain tumor that had something different outside of their tumor, and I couldn't figure it out. The first person I called was the master diagnostician, Dr. Robert Listernick. Bob.
Well, you know, I had to come to Phoenix for you to say nice things about me, but thank you, Stu. And just to continue the Mutual Admiration Society, I hope you guys realize what you've gotten in Dr. Goldman. I mean, we were talking at dinner last night, and it's been a significant loss to our hospital. And I don't think Stu understands really just how much of a loss it truly is, and he's truly missed. But now, since I only have 55 minutes left, my only disclosure is I've been a consultant for AstraZeneca. So what I'd like to do today is go through the diagnostic criteria for NF1, give you examples, go through some specific pediatric morbidities, a little bit about genetics and targeted therapies, and then sister syndromes. And I'm going to start as a segue. Todd Davis was, at the time when I started as a resident, the director of what was called ambulatory services. He was my continuity clinic attending. He hired me when I didn't know what the heck I wanted to do as a third-year resident. He did this for multiple people. He gave me the seminal NF1 article, distinguished NF1 from NF2 back in the New England Journal in 1984 from Vic Riccardi. So I owe everything in my career to him. And this is a shout out to the students, the junior residents, and young faculty that you never know where your career is going to be. You know, it's not going from A to B. It's going from A to B to C to D to E. And you pick up mentors along the way. So keep yourselves open to this. I mean, I'm one of the few pediatricians, maybe the only in the States that does NF. And, you know, it's made my career. So let's go on. I still have parents come or doctors refer patients to me for von Recklinghausen disease, not so much peripheral neurofibromatosis. And every now and then somebody comes in and says, you know, I was told my kid has elephant man disease. Well, here's the elephant man, Joseph Merrick. He did not have NF1 as far as we can tell. He did not have cafe au lait spots. You see his left arm is really nice and normal. That's sort of all strange. And we believe he now has Proteus syndrome, which is a mosaic mutation of AKT1 gene and overgrowth syndrome. And yes, Michael Jackson did try to buy his skeleton from the London hospital. That is true. All right. So you're getting a sort of a preview because the diagnostic criteria for NF1 have been changed, and for the other syndromes that I'll talk about. I'm going to go through them real fast here. 6 or more spots, cafe au lait macules greater than 5 millimeters in kids, 15 millimeters in post-pubertal individuals, axillary angle freckling, and you'll see a little hash mark. You have to, one of those two has to be on both sides of the body, because as I'll show you later on, we have mosaics that can be confusing. I'm going to go through each one of these in more detail. 2 or more neurofibromas, or 1 plexiform neurofibroma, an optic pathway tumor, 2 or more Lish nodules, and then a new criterion, 2 or more choroidal abnormalities, and I'll show you pictures of those, a distinctive bony lesion, and then finally, because we're in 2022, it's all about the genes now. We didn't have the genes when this all started. So then a new criterion was a heterozygous pathogenic NF1 variant. And I'll come back to that later. Okay, cafe au lait spots. One of the few things I learned about NF in medical school. That one I remember in 1975. Collections of heavily pigmented melanocytes. They occur in all races and all ethnic groups. If you probably, some of the older guys and gals know about Crow's sign. Crow was a dermatologist in Michigan, and he was a little obsessive compulsive, and he went into institutions and counted institutionalized patients who their cafe au lait spots, but he only started at 1.5 centimeters. So that's where that whole number came from. They're often present in birth and enlarge as the patient in the body grows. But interestingly, adults who have NF1 say they often fade. See, if you see an adult NF1 patient, you may not see that many. And then the important thing is 97% of kids under the age of 6 have 6 or more spots. Putting it the other way, if you're 10 and have a couple of spots, it's really unlikely that you have NF1. So here is typical cafe au lait spot. Here is a larger one, looks sort of like Australia. And the tip for the day is when you see something this big, always look and see if there's, or feel if there is a tumor underneath it. And I'll show you examples of that later. This child did not have that. And this is just to show you in darker skinned individuals, the cafe au lait spots are just darker. Okay, freckling. Really nothing special about it. Why kids freckle with NF1 where the sun don't shine? No idea. But it's quite characteristic. So many of the young kids I'm making a diagnosis on are based on spots and freckles only. And that can lead to a little diagnostic uncertainty that I'll come back to. Okay, 2 or more neurofibromas or 1 plexiform neurofibroma. Neurofibromas are not a single cell benign tumor. They make up of Schwann cells, nerve fibers, fibroblasts, and we've known in the last 10, 12 years that the Schwann cell that makes the myelin is the cell of origin. And it's the double hit. All the cells in the NF1 body have loss of one NF1 variant allele. When a Schwann cell loses the second lost NF1 gene, that's when you develop a neurofibroma. They commonly arise during puberty and pregnancy. Now, I have parents come to me, does this mean the moment my son starts getting pubic hair or my daughter gets breasted, they're going to have neurofibromas pop up all over the place? No, but there's clearly hormonal influence in some degree, because we don't see, I see young kids with very small neurofibromas, but it's rare to see significant burden of them. But there are plenty of cases of women who become pregnant that develop, like in a dermatome, a sheath of neurofibromas. When they're on the surface of the skin, they're very soft. They almost feel softer. They do feel softer than the surrounding tissue, and there's an expression that we use that I learned from my the dermatologist Nan Esterly, who was the queen of pediatric dermatology, from whom I initially got some of these patients, about buttonholing. You run your finger over it, and your finger goes into the skin. The neurofibroma because it's softer than the surrounding skin. And then when they're a little deeper, they feel like raw peas, quite different. Here's just an example. I don't know if my pointer shows on Zoom, but it does good. And you can see this sort of, often you'll see this little violaceous hue as a marker that there may be something there growing. And this is just an example of a woman who had many neurofibromas. And it's not that everybody has this. It's extremely variable, and we're finally beginning to look for things like modifying genes to figure out why some people with NF1 have a very low tumor burden and some people have multiple cutaneous neurofibromas. And this is the classic dumbbell neurofibroma on the dorsal root going outside of the cord and coming into the cord, compressing the cord on this arrow here. Now, cutaneous neurofibromas are not a big deal in kids, but plexiform neurofibromas are a major source of morbidity in the pediatric population. Plexiform means a network of blood vessels or nerves, and in our case, it means you can feel these large wormy tumor masses. There's often overlying hyperpigmentation. I'm going to show you a lot of examples in a few minutes. Under the microscope, they look like neurofibromas. There may be a lot more intracellular matrix because some of these are very soft rather than being lumpy, bumpy. And they grow along nerves and they spread into deep tissues. So that's why it's almost impossible to completely remove a plexiform neurofibroma. And that leads into what the development of newer therapies. They're generally present at birth or develop in the first few years of life. So something I learned from the NF1 maven, Vic Riccardi, is that if a 5-year-old comes in and there's nothing on the outside, that's a good thing you can tell the parents. He or she is not going to develop one of these plexiform neurofibromas, at least on the outside. We'll talk about the inside later. So here's a classic one on this boy's shoulder. It's quite common to have this hyperpigmentation, and also you can see over here and over here it's sort of this coarse hair that also can be a clue in the very early stages. There's something there. Here's a bigger one, more hair, more pigmentation. But once again, this is on the back, and this is all superficial. But you can imagine if it's on the face, if it's on the eyelid. We have a number of kids that have significant visual problems from plexiforms, either on the eyelid or behind the eye, pushing the globe out, causing proptosis, leading to amblyopia. Glaucoma, there's an association between a lid plexiform neurofibroma and development of glaucoma. And I mentioned proptosis, and of course, loss of function. We have, Dr. Goldman and I have one lovely young man now who I finally transitions to the adults, but who has a huge plexiform in his belly and in his leg. In fact, I have a picture in a minute, but it's wrapping around his bladder, and he's had bladder outlet obstruction and his whole life. And of course, in the spinal cord and leg length discrepancy. I showed this picture. Here's a boy just in his left upper eyelid. And you can see sometimes we see overgrowth. You can see how his eyebrow is thicker. And this is one of my many bugaboos that I don't like, because you can see this is several years later. And if you look closely, there's that scar there. Some plastic surgeon didn't know what he or she was doing, didn't look at the kid's skin, and biopsied this and left the kid with a scar where it was clearly a plexiform neurofibroma. This is another teaching point. So this girl obviously has a plexiform neurofibroma here, but what she had at birth only was nothing in her eyelid, but she had this big eye. It's called ophthalmus or ox eye. So she was thought to have congenital glaucoma, and that's an iridectomy scar at 10 o'clock. But it wasn't until the tumor started growing that people realized she had NF1. This is just an example of a girl who's had multiple surgeries on her face. Here's another teaching point. particularly for when the NF clinic gets started here. Always tell the residents, examine the whole body. So this was a teenage boy who was in his gown, but he had his sneakers on. And the resident said that he had spots and freckles and whatever. And I go in the room and I see his sneakers on. I take off the sneaker. And if you look closely, you can see this whole thing here is a plexiform neurofibroma. He'd been wearing different shoe sizes his whole life and just thinking that's what it was. But if you felt this, it was sort of lumpy, bumpy, and he clearly had a tumor there. So examine the whole body. This is what happens when it's on the inside. This girl ultimately died of a malignant peripheral nerve sheath tumor years ago. But this had been found, but it was not followed as it should have been. And there's an associated scoliosis. But you can see how it's wrapping around things, and it's up here as well. And this is the young man who had it in his belly. This is his leg. And everything that's bright there is tumor. So he had a very large, sort of basically not particularly functional leg, and he eventually had an AK amputation. And now this is something to be on the lookout for as well. We'll talk about genotype-phenotype correlations later, but there's a condition that we call spinal NF, where in fact they have very few cutaneous lesions, but every dorsal root on this young man is full of tumor. And incredibly, he's asymptomatic from this. Doesn't mean he's always going to be, but every dorsal root has this. Okay, so we could spend an hour talking about this. Optic nerve glioma, and I could spend more than an hour talking about optic pathway tumors, but I'm going to leave it on 2 slides. So here's in the early stages of our clinic, we were doing CT scans on everybody. And here's a girl who had a nice normal CT scan, nice normal optic nerves. And then this is her same MRI scan 15 months later. Developed a huge tumor, proptosis, involving the chiasm. So what have we learned? We've learned that if all children with NF1 undergo neuroimaging at the time you diagnose NF1, 15% of them will have an optic pathway tumor. However, of that 15%, only about half will ever cause symptoms. And of that half that ever cause symptoms, only about 30 or 40% will ever require treatment. So really, it's not the devastating thing that parents read about, my child's going to go blind, but it's certainly a significant source of morbidity. This is another whole hour lecture, but there's clearly in every study that's looked at it, a 2-to-1 female predominance, and David Gutman, who maybe some of you know, who is probably the best NF1 researcher in the world, has shown that there's something to do with microglia, the immune cells in the brain, and with a hormonal influence in female mice that contribute to this pathology. And there seems to be lower incidence in African American kids. These are tumors of young children. The slide has median age 4.9, but it's probably much younger than that. And the other way of looking at it is virtually all symptomatic tumors, not 100%, but most are diagnosed before the age of 6, 7. So if you have an 8, 9-year-old who has a normal eye exam or even a normal MRI exam, in general, that is not something you have to worry about. It took me and David Gutman and my colleague Ross Ferner in England to put together something like 7 cases of adults who presented with optic pathway tumors. So it can occur, but it's very, very rare. How do these kids present? About 70% have an abnormal eye exam, decreased acuity, pupillary dysfunction, an afferent pupillary defect, or on fundoscopic exam, optic disc elevation or edema. An important point for the residents and pediatricians that are watching, kids don't complain of gradual vision loss. The story I always tell was a kid who had dropped, a 5-year-old who was previously healthy, hadn't even been diagnosed with NF, who dropped a Cheerio on the carpet, and the parents saw him literally, his eye a half an inch from the carpet, looking for the Cheerio, and his vision was 2,300 in each eye, and that been long standing, and he never complained of anything. And then 30% of kids, and I have a slide in a minute, have precocious puberty. We'll talk about that. The risk factors for progressive disease seem to be very young kids and clearly posterior location. So tumors of the chiasm or the optic tracts or radiation are much more likely to progress and need treatment than tumors pre-chiasmal. I mentioned precocious puberty. This is often a presenting manifestation. We're pediatricians. We're used to keeping growth charts. There are kids, I've seen kids, I remember one 7-year-old boy that looked like you wouldn't want to meet him in a dark alley. And he had really grown. And he was going to, I won't say what kind of doctor, but it never kept a growth chart. And he clearly had precocious puberty and he had chiasmal tumor. So we keep very careful growth charts. And this is really not something that's really associated with NF1. This is associated with chiasmal tumors. I don't believe that it's a separate relationship with NF1. And like I said, we always keep growth charts. So this is opinion. I will come out and say this is the way I feel about things. But these are the facts. If all children with NF1 undergo diagnostic screening, neuroimaging at the time of diagnosis, as I said, half of the tumors that are detected would never cause symptoms, and many, 60% of the symptomatic tumors won't progress. On the other hand, let's say we screen only the young kids, just like that CT scan and MRI I showed you. She had a screening CT scan, and then before we can even see her again, she developed a big tumor. So I strongly believe that screening neuroimaging is not indicated. Now, I will say we really wrote the early papers on this. I would say most, but not all NF clinics do this. There are still some very big, very good NF clinics that will do imaging, neuroimaging at the time of diagnosis. And this is simply, don't focus on the numbers. This is just a reminder for me to tell you that there's a bit of paradigm shift since Dr. Goldman started doing this. But as an oncologist, I mean, rightfully so, as a neuro-oncologist, they were focused on the tumor. Does the tumor grow? We got to prevent the tumor from growing. Well, the paradigm shift is now we're really worried as much about vision in these optic pathway tumors. And this is from a large retrospective study that was done that Mike Fisher at CHOP was the primary author. And basically it showed that some kids' tumors grew, but their vision stayed the same or got better. Some kids' vision got worse, but the tumor stayed the same. So now any study of NF1 optic pathway tumors is going to look at vision as well as tumor growth. So that's all I'm going to say for that at the moment. The next criterion is the second thing I learned in medical school about NF1, Lish nodules. 2 or more Lish nodules. I'll show you the example. But the new criterion that was pushed forward by Rob Avery, who is the next generation of NF1ologists, we call ourselves very smugly. Rob is a neuro-ophthalmologist at CHOP. 2 or more choroidal abnormalities seen on OCT or near infrared reflectance imaging. I'll show you examples in a minute. So Lish nodules are slightly raised hamartoma of the iris, so abnormal growth of normal tissue from the melanocytes. They're basically pathognomonic of NF1. They don't cause any functional impairment. If they're present, they're very helpful. If they're not present, they're not so helpful. So about 90 to 95% of adults with NF1 will have Lish nodules, whereas only about 30% of kids under the age of 7 have Lish nodules. So their presence helps us, their absence doesn't. And this is what they look like. This is an extreme example with the naked eye looking, and you can easily see these dome-shaped lesions. This is what they look like with a slit lamp, and quite characteristic. Now, the choroidal abnormalities that's new. These are not seen with the naked eye, and these are only seen with OCT. This is near infrared reflectance. This is not a normal thing one does in the clinic. And you can easily see them. As far as I know, they don't cause any functional impairment. They're like the Lish nodules. And this is, we'll talk about OCT, optical coherence tomography. Maybe some of you old guys have had this from your ophthalmologist, but this is a beautiful picture, and you can see the indentation sort of right there and right here. This is the retinal neurofibromatosis layer. I'll show you examples in a minute later. Okay, the distinctive bony lesion. There are two that qualify for being distinctive enough. The first is sphenoid wing dysplasia. This is pathognomonic of NF1. If you remember, the sphenoid wing is the back wall of the orbit. It causes a congenital mesodermal defect. It's from a congenital mesodermal defect. It's not due to erosion from a plexiform neurofibroma, although we sometimes see them together. And it can cause a really cool, well, before I get there, any radiologist worth his or her salt will recognize, here's the sphenoid wing, here's an absent sphenoid wing. So this is see one, do one, teach one. Oh, I'm gonna have to cancel that, I guess. I need help with that. Okay, so this was going to be an example. Somehow it didn't come across on the internet, of pulsating exothalamus. So if you're missing the back wall of the orbit, think about it. Every heartbeat can get sensed by the globe, and this is a really cool thing. I have a different example, which I can't show, of the eyeball bugging in and out, sort of a Roger Rabbit type of thing for those who remember Roger Rabbit. The other pathognomonic bony lesion is dysplasia of a long bone, almost always the tibia, although the radius can be affected as well, or the fibula. About 50 to 97% of kids who have tibial dysplasia have NF1. If they don't have NF1, it's probably mosaicism of that radius itself. On the other hand, 1 to 3% of kids with NF1 will have tibial dysplasia. It can be anywhere from just a little thinning to like a frank pseudarthrosis, a false joint. And once again, it probably is due to loss of heterozygosity of a cell in the bone there. And the mainstay of therapy really is preventing fractures. In the old days, when I started, it wouldn't be uncommon for a parent to come in with an AK amputation because once it was broken, you couldn't fix it. Now with the Elizaroth frame, those things with all the spikes that can hold in bone grafts, you can basically save the leg, but we really try to avoid that. And here's just several different examples. Here's the thinning. Here's a frank break, and this is, if you look at the skin, you'll see another joint there. It's sort of a false joint, pseudarthrosis. However, really the most common bony defect in NF1 is scoliosis. In some studies, as much as 10% of the kids. And there's two types. There's the same type that we as pediatricians know to look for in prepubertal kids, around, girls around the age of 9 or 10 when they're going into puberty, the idiopathic scoliosis. But then you can have a short segment dysplastic scoliosis like this. Obviously, we try and avoid this, but kids are born with abnormal vertebral bodies and thinning of the ribs. And this is, once again, classic for NF1. And then finally, because once again, it's 2022, new criterion, a heterozygous pathogenic NF1 variant with a variant fraction of allele of 50% or more in tissue. So in other words, somebody who's heterozygous in every cell in their body for an NF1 pathogenic variant. And we'll talk about genetic testing later. Well, we'll talk about it now, excuse me. So NF1 is an autosomal dominant disease. It's on the long arm of 17. It affects anywhere from about 1 in 2,700 to 1 in 3,000 individuals, depending on which study you read. So if you're starting an NF1 clinic here, 1 in 3,000, that's nothing. I tell my parents come in when they're shocked that their kid has NF1, I say there are at least 1,000 kids in the city of Chicago who have NF1 in the city of 3 million. From your catchment area, you're going to the walls are going to be knocked down, even with forgetting about the kids that are already in the system. Another thing that I tell that parents don't quite get initially is that the penetrance is 100%. If you have the gene, you will have NF. If you have the NF, the pathogenic variant, you will have NF1. It doesn't skip generations. However, expressivity is is extremely variable, even within families. So why that's important is, parents will come in, and I've diagnosed, I don't know, 50, 60 adults with NF1 over the years, and they were just sailing through life with some spots and some skin tags that they thought of, and nothing made of it. And their kid comes in and has a brain tumor or has a plexiform neurofibroma on his or her face. So the point is, expressivity is extremely variable, even with families. And once again, we're now starting to look for modifying genes that could say, why does somebody get a big tumor burden? Why does somebody get a plexiform here and somebody get a renal artery stenosis, as an example. Another precept that it seems pretty intuitive, but I think people don't get it initially, is that the older you are, the more likely you have a complication. So, parents say, well, once my kid's out of childhood, everything's going to be fine. Well, I really can't say that. And then finally, there are a few genotype-phenotype correlations. There's one that conveys that kids just get, there's several, I should say, where kids just get Lisch nodules, cafe au lait spots, freckling, and no neurofibromas, but it's an NF1 pathogenic variant. But the one that you probably should remember, that there are several different whole gene deletions. And because of the contiguous genes that are deleted, it conveys a different type of phenotype. These kids have a much greater tumor burden. They have many more neurofibromas, plexiform neurofibromas, a higher rate of malignancy, which we'll talk about in a minute, malignant peripheral nerve sheath tumor, and a higher rate of neurocognitive disability. And I don't remember whether I say later on, but because these kids have such a higher rate of cancer, I generally many NF clinics are now doing whole body MRIs. That's something we'll talk about in a minute on this particular group, when we can get it done without general anesthesia, just around, hopefully, depending upon the kid, around the age of 10, or maybe a better kid around 8 or 9, just so we can see what the tumor burden is. The gene product is called neurofibromin, no surprise, and it's ubiquitous, expressed in many cells, neurons, glia, Schwann cells. It's ubiquitous in fetal life, which is probably why there's such a wide phenotype. And it's a gap protein, a GTPase activating protein, which down-regulates the RAS oncogene. So think about it. RAS, if RAS is downregulated and allowed to proliferate, you have unrestrained cell proliferation, and you get all the different manifestations. So, it's 2022, a little genetics. So here, I'm not going to test you on the MAP kinase pathway, but there's a lesson in this slide. So there is the NF1 gene right there, converting KRAS back to inactive RAS. But there, look, and there are 3 arrows, but I didn't want to clutter the slide. That's Noonan syndrome. And there are about at least 12 Noonan genes, and that only accounts for about 85% of Noonans. And there's a big overlap in phenotype sometimes between Noonans and NF1. And I've made the mistake, and I'll show you a little later on, of misdiagnosing infants with Noonans who have NF1 one time, and NF1 who had Noonans one time. So that I now will do genetic testing. I'm jumping the shark here a little bit. I do genetic testing in any kid in whom I'm not think they have Noonan syndrome. But then look further. That's Costello syndrome, an HRAS mutation. That's cardiofacial cutaneous syndrome. All these kids, some of them have cafe au lait spots. Some kids with Noonan syndrome can have spinal neurofibromas. So there's definitely an overlap there. This is capillary malformation AVM syndrome. No confusion with that one. And then finally, I put spots and freckling because over here is the spread1 gene I'll come to at the end of the talk that causes Legia syndrome, which is a sort of confounder for some of us in NF world, but I'll come back to that. But the point is, we now look at the molecular landscape. That's much more important than giving it a name. Okay, so let's talk about some of the comorbidities in kids. And there are many, but I picked the three most common ones. There's neurocognitive, malignancy, and vascular. Parents, they come, the kid has spots, the kid's 3 years old, has spots and freckles, and they've read online that their kid is going to have severe mental cognitive impairment. He's never going to graduate high school. Bogus. The mean IQ of the NF1 population is 95. I admit that I confabulate a little bit, and I tell parents that the IQ of an NF kid is the same as the IQ of a non-NF1 kid. It is shifted about 5 points over to the left. There is a higher incidence of severe cognitive impairment, but it's very low. I mean, that's very low. We have a few kids who have very low IQs. But there is, and once again, this is another hour talk. In fact, on our NF meeting in June, there's going to be a whole session on autism. Once again, David Gutman is leading the world in this. But there's a significant instance of autistic features in NF1, even if they don't meet the formal diagnosis for autism. There really is no association between IQ and any of the clinical variables except the whole gene deletions that I mentioned. But one big thing is that there's a marked increase in incidence of learning disabilities and ADHD. Probably of 60% of the kids have some combination of ADHD or learning disabilities, and stimulant medication can be life altering. Visual spatial function is something you'll hear a lot talked about in the NF world. Not being able to orient things in space. I know I could never have been a radiologist or a surgeon for many reasons. I'm not smart enough, but also I know I have a visual spatial deficit. I can't see things in 3 dimensions. That's probably why I almost failed anatomy. What's interesting, and I'm not going to spend much time on this, turns out NF1 mice have the same cognitive deficits of NF1 kids. And this was a big thing 15 years ago because it was found that the learning deficits were due to upregulation of RAS. And in mice, if you down-regulated RAS, they had normal learning. What's more, it was shown that a farnesyl transferase inhibitor can reverse the learning deficits in these mice. And then one day in one of the big NF1 researchers' labs, a medical student, lowly medical student came in and said, I just learned in my pharmacology course that the statins inhibit RAS. So, whoa, that was a huge thing. So there was this huge, one of the early NF1 consortium trials was looking at a randomized placebo-controlled trial of lovastatin to try and reverse learning disabilities in NF1 kids. Now, this was this was an incredibly difficult study to do, and I think they learned a lot from it, but the bottom line was it didn't work. I think there are still centers looking into this, but as far as we know, there's nothing that will reverse pharmacologically the learning disabilities in kids. All right, let's talk about cancer. Dr. Goldman knows, that JPAs, juvenile polycystic astrocytomas, are one of the big benign tumors we see in kids with NF1. Optic pathway tumors are JPAs. We do see higher grade tumors. Once again, it's very rare. I wrote a paper with one of your neuro-oncologists here, and I think we found 3 kids, one who had anaplastic astrocytoma, one who had a GBM, and I think one who had a medulloblastoma, who had NF1, but it's really rare. But the cancer that we really worry about is a malignant peripheral nerve sheath tumor. This occurs, there's a lifetime risk somewhere between 8 and 13%. It generally, I would say, virtually always arises within a pre-existing plexiform neurofibroma. Now think about it. You're trying to find a new cancer within a pre-existing tumor. So that's difficult, and I'll come to that in a minute. So what the mantra is, if your tumor starts growing, if your plexiform neurofibroma starts growing rapidly, the plexiforms are always tender, but if it starts causing spontaneous pain or you have new neurologic dysfunction in any way, that's a red flag to look for an MPNST. These, once again, because they're buried within other tumors, have a pretty bad prognosis unless you can get the whole thing out. It's a sarcoma. There is definitely an increased risk of leukemia, specifically AML, specifically juvenile myelomonocytic leukemia, JMML, and then I have seen several kids with actually prostatic rhabdo. I think there's something about prostatic rhabdos, but definitely that. Adults, I used to say I've never seen a kid with a pheochromocytoma. Well, sure enough, 2 weeks ago, I had my first patient who had an asymptomatic pheo, but long story, but it's very rare in kids, gastrointestinal stromal tumors, GIST, and glomus tumors. These are interesting. I've always learned to look out. Glomus tumors are in the glomus bodies are on the fingertips and the toes, and they get these benign tumors that cause exquisite pain. So if you ever have a kid with NF or an adult with NF1 with exquisite digital pain, think about a glomus tumor. And then finally, big thing in the last decade, we now know for sure that there's an increased risk of breast cancer in women with NF1. You can see the risk, and now the protocols are for starting screening at the age of 30. So we have new tools now. I mean, most of you probably know about PET imaging, but here is an example of finding a tumor within a tumor. Here's the plexiform neurofibroma, and here's a hot spot that we see with PET. So that can be very helpful, and we often do delayed imaging based on some research. The other thing that has come to the forefront more recently is diffusion-weighted imaging and ADC mapping. DWI quantifies the motion of water molecules into the tissues. So the idea is if the tissue is thicker, you're going to have less diffusion. And the same thing for ADC mapping. You assign a numerical value to how cellular the tumor is. So there's pretty good evidence now that in plexiform neurofibromas, low ADC values less than 1 are suggestive, just like the PET's imaging of a malignancy. Just a word on vasculopathy. Here's moya, puff of smoke, no perfusion up here, and here's a renovascular disease. So we always take blood pressures in the NF clinic at every age. And we certainly have had a number of kids who have needed stenting or even reimplantation, of the kidney. Okay, so let's talk about treatment for just a little bit. There were many barriers to finding NF1 specific treatments. There weren't a large number of patients with, let's say, vasculopathy to figure out treatment. There were NF1 tumors have variable growth rates. This was the biggest problem with trying to find plexiform treatment. Initially, they were treated with conventional chemotherapy, and they stopped growing. Well, they're going to stop growing anyhow. So it was really hard to do studies, and it still is really hard to do studies on them because they don't behave like classical tumors. And then we had it's one thing to image a nice round brain tumor. It's another thing to image, think about trying to treat that kid with a plexiform up and down his leg. The Department of Defense NF Clinical Trials Consortium was started. This is an older map, but there may be a few other centers. We are a part of this. And then even more importantly, in many ways, this was started by David Gutman. I'm blocking his name, Plotkin at Mass General Hospital, and Brigitte Wiedemann at the NIH. How do you assess response to treatment? I just said it isn't easy. So we have multiple subgroups. I was on the visual group. How do you decide, measure vision outcomes? How do you measure quality of life? How do you measure hearing in NF2? There are multiple subcommittees, and it's really a crucial thing that these guys did. And so just an example, here's the volumetric MRI if you haven't seen one. And somebody painstakingly traces out the tumor, and the computer averages and gives you a volume in 3 dimensions rather than an area in 2 dimensions. The other tool that we have are our tricks now that you're going to hear more about is whole body MRIs to assess tumor burden. And then finally, we're now entering in the era, because now we have a targeted therapy of treating cutaneous neurofibromas. But how do you measure those little buggers? So here's with calipers, here is with high 3D photography, and here is high frequency ultrasound. You're going to hear a lot more about high frequency ultrasound measuring the volume of tumors as we get into the era of doing clinical trials on cutaneous neurofibromas. Most of you, or certainly the oncologists, know about selumetinib, a MEK inhibitor. This is from the New England Journal article, and this was like, a red letter day for the NF community. We now have a treatment for plexiform neurofibromas. You can see his MRI on the left and what happened visibly on the right. All right, that's all I'm going to say about treatment because I only have a few minutes left. What do I do when I see a kid? I take a good history. We do a physical exam, including a detailed neurologic exam. I think every kid with NF1 should have an eye exam yearly, at least until the age of 10. We were fortunate that we started our NF clinic in the ophthalmology clinic. So that's how we were able to capitalize on the research that we've done. We do a physical and a slit lamp. I don't examine every parent, but I will examine them if there's any suggestion that they might have NF1. Certainly, if the ophthalmologist sees Lish nodules in the parent that's there, I will absolutely examine him or her. And I don't do baseline studies. Now, that's me. I know that there are clinics that will do it, but I don't recommend routine neuroimaging. So about the new era of RNA technology, using that 98% sensitivity. We can do targeted mutation detection. We can offer prenatal testing. Now, I will say, I don't routinely do this. There are other clinics that are routinely doing this. It's expensive. I don't want to put a financial burden on the family. We always get prior approval, but I do use it in certain circumstances. Like I said, whether I'm not sure whether the kid has Noonan's or NF1. We have one family who has constitutional mismatch repair deficiency, an incredibly interesting disease that I don't have time to talk about. So I will use genetic testing. And I have to say, parents are asking more and more kids that come in with spots and freckles. They want to know for sure, and I'll show you why. So if they want it, I will do it, and clearly for family planning purposes. All right, we're in the home stretch. So let's talk about some variant syndromes. The reason I was talking about spots and freckles is because there is a separate mutation in the SPRED1 gene. I showed you that on the slide. Named for Eric Legis, who is the NF1 geneticist guru in Leuven, Belgium, who identified and found the gene for families where there are multiple cafe lay spots, freckling, macrocephaly, maybe some learning disabilities, but no neurofibromas, no Lish nodules, no bony dysplasias, and it's autosomal dominant. But it's nowhere near as common as NF1, but it is something I will consider testing for if a kid's like 10 or 11 and still hasn't gotten anything that makes me think that they have NF1. So the next variant is mosaic NF1. Think about it, so that there are kids who just have clearly a segmental distribution of cafe au lait spots or freckles. This is the new criterion that I just literally saw, even though it was on the paper for the day before. I had to send in the slide, so I had to change this slide the day before I sent it in. Because there have been kids, because of gonadal mosaicism, born with full NF1 to a parent who just has some cafe au lait spots on his or her abdomen. And here's a great example of segmental NF1, which is in a dermatomal distribution of all these neurofibromas. I've never seen anything like this. This is from New England Journal. But okay, good. I'm going to leave plenty of time for talks. Now we're coming to talk about NF2. Now, forget about everything on, all the bullet points there. Simply, let me just say that NF2 is a much worse disease. It's on the 22nd chromosome. I'm going to the next slide, but it's characterized by this bilateral vestibular eighth nerve schwannomas. That's the hallmark. Usually the average age is in the mid-20s for the development of these tumors. A devastating disease, fortunately about 1 in 50,000, much rarer. These kids get meningioma. Not only do they get hearing nerve tumors, they get meningiomas, schwannomas, glioma, no longer gliomas. I'm going to show you something in a minute. They can get, kids present with visual problems quite commonly. They get cataracts, posterior subcapsular cataracts, retinal problems. It's a really bad, devastating condition. The name is changing. No longer use NF2. You'll see that on my next to last slide. And there's an example of bilateral vestibular schwannomas. The gene, as I said, it's about it's on the long arm of 22. The protein, sweetly, is called Merlin. Don't ask me why. And it sits on the cytoskeleton. The final condition that I'm going to mention, this is my next to last slide, is schwannomatosis. I have never seen this. You guys will probably never see it, but you should know about it. These are people who get multiple non-cutaneous schwannomas. Now, it doesn't sound so bad, but they are painful. So these people live with severe, debilitating pain. And in its own way, it's a horrible disease. And there is a little overlap with NF2 because there have been some people with schwannomatosis who have gotten the vestibular schwannoma. But 90% of the cases are sporadic, but it can be autosomal dominant. We know at least 2 genes, SMARCB1 or any one that the neuro-oncologist will know, or LCTR1, causes most of the familial cases. But most of the cases with schwannomatosis, we haven't discovered a genetic cause yet. And then finally, and I'm not going to go into the long details, I was part of a an international Delphi conference where we went over the NF1 criteria and the NF2 criteria. And literally, this slide I had to change the day after I had already sent it in because I got the final manuscript. And they changed the names once again. But the new names that you're going to start seeing promulgated for these diseases because there's such an overlap between them. And once again, we're talking about gene-related diseases. So NF2-related schwannomatosis, SMARCB1, LCTR1, abnormalities in a 22q long arm, and then people who have schwannomatosis where you can't identify the genetic cause. This is going to be the new terminology the insurance companies are going to have to deal with and doctors, and it's just going to start being promulgated by the powers that be this year. Good. I got 6 minutes left, and I'm happy to answer any questions. Thank you. Should I click on chat or?
There's nothing in the chat or Q&A yet.
Okay. Yes, sir.
Could you comment a little about the cardiac association with the number of studies listed, 16%?
I'm sorry, I missed it for the what?
Cardiac association.
Cardiac. I don't know what to say about that. I mean, there are researchers that look at the embryology of NF1. I don't see heart disease, so I don't understand it. I just don't see, what I consider a significant incidence of heart disease. But yes, I mean, that is definitely out there in the literature, and it's certainly true embryologically when they look at zebrafish and such. But I don't see it clinically. I don't think I'm missing it. You please comment if you have
No, we just published where there's about a 60% incidence. A lot of it's aortopathy.
I do have one kid with an aortopathy, but I mean, maybe I'm missing it, but we certainly don't do echocardiograms on kids unless there's a clinical reason. There probably are clinics to do that. This is what, were you doing echoes on all the kids? Yeah, maybe we should be doing it. I don't think most clinics are.
A lot of them are.
Yeah, well, that's the thing. So that don't kiss, don't tell.
Another question is the NF1 vasculopathy that's what I understand. When we talk about it as well, it certainly doesn't seem to be well.
In what way do you say it? Because I would.
The incidence of stroke with NF1 vasculopathy is relatively low.
Yeah, I don't know. There aren't that many big studies of big populations of NF1 and stroke. In fact, we're looking at transcranial Dopplers now to see whether that can pick it up, comparing it to MR angiography. But we have a couple of kids who had stroke, but I'm not aware of a reference of in a large population where it exists.
We published a scientific series, but the
Interesting. Yeah. Are you a neurosurgeon? Oh, okay. Yeah, we've had a couple of kids with stroke. We've had a couple of kids who've had EDEMS procedures, but I haven't looked at it systematically. Any more?
One last question for me. There's nothing in the chat. I wanted to know, with the schwannomatosis and all those things, how common are those? Because kids that are in the hospital or in the clinic that have chronic pain are pretty frequent.
I don't think you're gonna. I mean, it usually presents in their 30s, so I truly don't think it's a pediatric disease, and I don't think you have to, unless the kids have tumors that are found. I don't think you have to worry about that. But I mean, it's always good to get a family history, right?
Right. The question is, I mean, most of the time, I mean, it's not that frequent. Parents want imaging or something, and there's nothing else to really push at imaging other than somebody's having pain, and then if some imaging is done and it doesn't show any obvious tumor, then the question is, well, do you dive deeper?
Well, people with schwannomatosis have tumor. They do have schwannomas. They don't have occult pain without having a tumor there. I don't know the pathophysiology of the pain, though. Did you want to, Dr. Goldman?
Yeah, great talk.
Thank you.
For coming. As we expand our NFP outside of a neuro-oncologist, which we know by definition is important, what do you think the great makeup you need?
Yeah, neuro-oncologists are okay. I think, one size doesn't fit all. I mean, I'm a general academic pediatrician. I'm not a subspecialist. And the problem is, and I was telling Ross this last night, if you build it, they will come and you'll start getting kids with 2 or 3 or 5 spots, and you don't want to see them as an oncologist. So my bent is you need somebody in the front line seeing them. And I'm not even sure a neurologist wants to see all the kids with spots, but maybe he or she does. So my bent is get somebody who really wants to see the kids, and yearly who just has spots and freckles and learning disabilities, much bigger morbidity than brain tumors in kids with NF1 who's seeing them. Maybe this gentleman wants to be that person. I don't know whether you want to see all the spots or not. But you need, obviously, in a hospital like this, you have everybody you need. You need the neuro-oncologist, you need the oncologist, you need. I don't know whether you necessarily need a geneticist, but our clinic coordinator is a genetic counselor, and I couldn't exist without her. And then obviously an ophthalmologist and all the other, I see it's 8:30, all the other subspecialists. But who leads it? That's up to you guys. But whoever it is needs to want to see spots, because that's going to be your bread and butter. And I don't know whether this gentleman wants to see spots or not. as a pediatric neurologist.
I had the good fortune of treating Bruce Cole.
Oh, well, okay, he likes to see spots. He's a neurologist and a geneticist.
I just wanted to comment that one of the underappreciated about the chief comments as well is not routine imaging. And for me, it was for starting so much inside.
Absolutely.
The numbers are always also the tumor is twins, the tumor is twins, so it's a very small fraction that we have to listen to that.
And I think, oh, go on, I'm sorry.
No, I think it's 8%.
Right, exactly. And I'll just say, and I know it's 8:31, that I think Bruce is talking or in a webinar at noon, but I lost my point. Oh, you're going to be seeing a whole new era of imaging, of whole body imaging. In fact, we're on the cusp of, from the NCI, doing a very long-term study of plexiform neurofibromas that starts with neuroimaging, with whole body imaging at diagnosis. And that absolutely needs to be done. The question is now, can we prevent these internal plexiform neurofibromas from causing morbidity by picking them up early and maybe using selumetinib or another MEK inhibitor early? So it's a whole new era and a whole new question that has to be answered. And that probably won't be answered for 10 years or more.
After 20 years, I've always wanted to get the last word in.
Go for it.
Possible in dealing with
I'm going to step away and
But I just wanted to again say thank you for coming out to Phoenix and sharing your expertise. Congratulations on coming out.
thank you for having me.
Thank you very much. Nothing more from the chat box except good job. Thank you for the talk. And for anybody who missed it, the attendance code was 898322. Came a little bit late, but we did have it. 898322.